Hypopharynx cancer is basically the inferior pharynx. It runs from the level of the vallecula, so right about here, down to the level of the cricoid cartilage. 60% risk of occult nodal involvement for T1 to 2, and literally 85% for T3 or greater. Subsites include the 3 Ps, the piriform sinus, the posterior pharyngeal wall, and the postcricoid area, which is the anterior portion of the pharynx between the vallecula and the cricoid. So if we're looking at an area here, this is the hypopharynx, this is the larynx. The larynx is essentially in front of the hypopharynx. So if you're looking down at the larynx, here's the epiglottis. Anteriorly, here's your vocal cord. Here is the piriform sinus. This is the posterior cricoid area, posterior pharyngeal wall, the left piriform sinus. In terms of workup, globus sensation, something stuck in the throat and can't clear. Staging is generally the same as larynx. T1 is less than or equal to 2 centimeters, 1 subsite. T2 is 2.1 to 4 centimeters, or 2 plus subsites or an adjacent site. T3 is greater than 4 centimeters, or hemilarynx fixation or esophageal involvement. T4A is thyroid or cricoid invasion, hyoid bone invasion, thyroid invasion, central soft tissue. T4B is prevertebral space, the carotid artery and mediastinal structure invasion. In terms of management for T1 to T2 and 0 tumors, you can do a partial laryngectomy, larynx preservation with lymph node dissection. Adjuvant radiation is indicated for PT3, T4 tumors, N2 to N3, perineural invasion or LVSI, or adjuvant chemoradiation for positive margins or ENE, or you can do definitive radiation. For T3 tumors or node positive resectable, you can do chemoradiation definitively. You can do total laryngectomy with lymph node dissection. This is preferred for T4A or non-functional larynx with high aspiration risk, with radiation or chemoradiation is indicated, again for these reasons up here. Or you can do radiation, you can do induction chemo followed by radiation or surgery. TPF every 3 weeks, times 3 cycles, and then if you have a complete response, you can do radiation. If there's no complete response, 2-3 cycles of TPF, then you do total laryngectomy with lymph node dissection. For T4A disease, you do total laryngectomy with lymph node dissection. Chemoradiation or induction chemo is category 3. For T4B or any tumor that is unresectable, you do chemoradiation. Definitive chemoradiation is extrapolated from RTOG 9111 for larynx. EORTC 24891, Lefebvre 2012. This is looking at the role of larynx preservation with hypopharynx cancer. This is 202 patients with squamous cell carcinoma of the hypopharynx, mostly piriform sinus, and the larynx involving the arioepiglottic folds, stage 2 to 4. They were randomized to either surgery with post-op radiation versus induction cis-5FU, followed by radiation if there was a complete response and surgery if there was a partial response, much like the VA larynx trial. There was no difference in overall survival between surgery and post-op radiation versus induction with radiation or surgery thereafter, 33% for both. Chemoradiation does decrease the distant metastasis rate versus surgery. The 5-year intact larynx rate was 35%. But of patients with a complete response, 65% had larynx preservation. Bottom line from this EORTC 24891, Lefebvre 2012, larynx preservation with hypopharynx. Larynx preservation with induction chemo for the hypopharyngeal cancers yields outcomes similar to surgery, but overall prognosis is still poor regardless. The other trial is Gortec 2001, Pointreau, JNCI 2015. These were stage 3 to 4 larynx or hypopharynx. Over half were hypopharynx, 54%. The other got induction TPF times 3 versus induction PF times 3. Then all of them were then randomized to radiation, 70 gray for a complete response or partial response. If no response, they got a total laryngectomy with radiation to 54 to 66 gray. Required greater than or equal to partial response with vocal cord recovery to be eligible for this radiation. Eligible for radiation went up from 60% to 80%. The 3-year larynx preservation rate went from 60 to 70%. Overall survival between the arms was 60% with no difference. Bottom line is TPF resulted in superior response rates compared to PF. Hypopharynx is the only head and neck site for which induction chemotherapy is okay, and recall TPF stands for docetaxel, cisplatin, and 5-FU, or fluorouracil. Technique, definitive IMRT dose painting, 35 fractions, 70, 63, 56, in 2, 1.8, 1.6 gray per fraction. For post-op radiation, this is treated in 30 fractions, 60 and 54 in 2 gray and 1.8 gray per fraction. For EC or positive margins, treat 66. First echelon nodes would be bilateral retropharyngeal, levels 2 through 4. Level 6, if there's thyroid cartilage invasion, posterior cricoid cartilage invasion, subglottic involvement, or emergent tracheostomy was performed. CTV 63, which is your mid-range dose, should include the entire hypopharynx subsite, the entire larynx from the hyoid to the cricoid, and high-risk neck. GTV plus 5 millimeters is CTV 70. GTV plus 1 centimeter plus the entire hypopharynx subsite, the entire larynx, and the involved neck would be your mid-range dose. Constraints, none listed here. Toxicity, this is the worst prognosis in head and neck cancer. Overall outcomes, larynx preservation 60 to 80% depending on the method. Overall survival at 5 years is 40 to 50%. Local regional recurrence is 30%. Distant mets is 25%.